Good afternoon, everybody. My name is Garrett Schmidt. I'm the managing editor for ACOExhibitHall.com, and I'd like to welcome you all to today's webinar presentation hosted by Proficient Health, and it is called 2022 Technology Revolution, Using Innovation to Drive Quality in Value-Based Care Organizations. And I'm very excited to hear what these guys have to say today. I think there's a lot of fun things they're going to be discussing. A few items of note before we get started. Everyone has joined today in listen-only mode, so you don't need to worry about muting your mic or anything. That's been done for you. And also, the webinar is being recorded. So after the fact, what I'm going to do is probably later on today, at the very latest tomorrow morning, we'll be sending out a link to the recording where you can have access to that and be able to rewatch and share that with colleagues. And we hope that you do. And then finally, we're going to have several Q&A opportunities throughout the presentation today, and we would love to hear from you. So please don't hesitate to ask a question, and you can do that using your attendee module. There's an area on there where you can ask questions. So it's not in the chat, it's actually a little question thing. So please ask your questions. If we're not able to get to yours today, we'll make sure to respond via email afterwards. And so please ask your question if you have one. Real quick, I wanted to introduce our presenters, and then I'm going to hand it over to them to do a little more in-depth introduction. But Dr. Israel, who is the Chief Medical Officer of WakeMed Key Community Care, he's with us today. So welcome, Dr. Israel, and also Miss Erica Grau. She's the Director of Marketing with Proficient Health, and she's going to help to moderate the session today. So without further ado, Erica, I'm going to turn it over to you to get us started. So welcome, guys.
Awesome. Thank you so much for introductions, Garrett. And thank you everyone for joining us today. Our webinar 2022 Technology Revolution, Using Innovation to Drive Quality in Value-Based Care Organizations is brought to you by Proficient Health. As a leader in referrals management and provider communication solutions, Proficient Health helps complex health and provider networks align every aspect of referral management to deliver better patient care and strengthen financial and operational performance. Like Garrett said, I'll be your host and moderator today, Erica Grau, Director of Marketing here at Proficient Health. Today I am joined by our speaker, Dr. Roger Israel. He is Chief Medical Officer at WakeMed Key Community Care. He graduated from the Massachusetts Institute of Technology Medical School at the University of South Florida and received his internal medicine residency at Wake Forest University. He currently serves in a private internal medicine practice in Raleigh, North Carolina. Thank you so much for joining us today.
Thank you, Erica. Thank you,
awesome.
And thanks everyone for joining and stuff like that. So yeah, our ACO, which is WakeMed Key Community Care, just to give you a little background, was formed in 2014 as a joint venture between the independent physicians, which is called Key IPA, and WakeMed Health and Hospital System, in order to develop an accountable care organization, an ACO, in order to improve care for our community and our patients. So the ACO originally started pretty small, only about 30,000 members, but we have grown substantially over the years, and we now have over 600 PCPs. We have over 1,000 specialists in our HVS network, and we have over 200,000 covered lives with our contracts. So we've gotten heavy in the weeds about the world of accountable care organizations. What we have found is that in order to manage these lives, develop insight, and coordinate care, technology is playing an ever increasingly important role in achieving those goals. To that end, in 2019, the ACO decided to purchase a whole informatics system to integrate with all the different EMRs across our network and to develop a centralized data repository in order to get information both from EMR records and from claims data from the different payers we contract with. We then use this information to develop predictive analytic models and care management models, which we use in order to better coordinate care for our patients. In 2020, we actually decided to get a new referral management program, which is Proficient Health. and was able to bring that to fruition and get all of our practices and specialty practices to start using this so we can better coordinate the care of referrals and closing care gap loops and things like that. So that's how I kind of got involved in all this. And I think we'll go ahead and start taking some questions and talk about the process and the joys of technology.
Awesome. Perfect. So before we kind of dive into our first topic for discussion, just want to remind everybody that our webinar format will consist of prepared content, interview style, and then of course we'll have questions from the audience throughout the presentation. So as Garrett mentioned, if you want to drop those questions in the Q&A module in your GoToWebinar control panel, we would love to answer those now. All right, let's kind of dive right in. So let's go into our first topic, kind of the overall theme of this webinar. How can technology improve quality?
Yeah, so technology is really the heart of how we figure out how we're doing in terms of quality. What we were finding prior to integrating our own system was we were relying on payers to give us their quality measures for us. And always there's a 3 to 6 month lag in getting that information from payers. So by the time you learned that you were behind on a particular measure, it was already too late to do much about it. So to be much more proactive, we went ahead and instituted this new informatics system called Arcadia. And what it does is it reads EMR data every night from all the associated practices and combines that with claims data from all the different payers and gives us a dashboard where all the quality measures are listed by payer, and then we get to see exactly where we stand on any particular quality measure. And this has been very, very insightful because sometimes you do well in things you think you weren't and vice versa. And we found that one measure, for example, on diabetes, we actually were not doing as well on controlling patients with high A1Cs. And that led to development of an interaction with these with the practices to try different strategies to improve care management of diabetic patients. So that has been very helpful to kind of get insights into where we're performing well and where we're not performing well, but do it more in real time so we actually can manage the situation and not be months and months and months down the line and too late for that opportunity. So, and we'll probably talk more about the diabetes project later, but yeah, so you have to know where you are in order to know where you're going, and that's the insight that technology gives us.
I really like that. And I kind of have a follow-up question there. So how do you decide where to invest in like brand new major technologies versus where do you kind of pick within your workflow to make subtle changes? Does that kind of make sense?
Yeah, and yeah, a lot of it depends upon everyone's individual systems and what mix you're working with. For large hospital-based systems, for example, that use a single EMR system, such as Epic is the most common one, they probably have a little bit of an advantage in the sense that everyone's using the same platform, same data fields, and there are already pre-built programs that work within the Epic platform that helps you extract data and things like that. Unfortunately, we're not in that group. We have about 30 different EMRs that we have to connect to. So we needed to find an outside vendor who could actually make those connections with all these different EMRs. That process took us a year to complete. EMR companies, some of them are okay to work with, some of them are difficult to work with. They do not want to let you have access to data, even though a patient and a provider is involved in an ACO, that doesn't mean the EMR company is motivated to share that data. So it literally took us a year to get all these practices and all their various EMRs integrated into one system. Now, part of that is not just the connection on the front end, it's also getting the data to match across all these EMRs. So what a particular EMR calls a particular piece of data, which is called an ops term, is different between different EMRs. So you have to then go back to all these different ones and match up their ops terms with what's in their EMR, so it's all in one system. And then you have to take the claims data, because they treat ops terms differently sometimes, and have to match up the ops terms from the claims data with the ops terms from our EMR data. So it is a very extensive process to get everything lined up. But as true with all technology, garbage in is garbage out. So you have to put the time and the effort into getting it right on the front end so that you actually can make use of the information in the back end. And that's kind of where we are, luckily, now, is that we're now being able to use that data and feel confident about that data going forward with our decision making and planning for care management and quality measures.
Great. We have a couple audience questions that I'd love to hear your feedback on. So this is specifically about your org. Does the technology used by WakeMed include application of CMS algorithms to document each benefactory's optimal HCC?
So that is EMR dependent. So in our global system, Arcadia, it does have a risk coding module where a provider can go into Arcadia, see all the potential risk codes that were available, which both show what's available from EMR data, which is from the PCPs, and what's available from claims data, which tells you if someone went outside of our network, any risk codable information from that. And then the provider is able to then document in their EMR that they talked and dealt with the issue, and then code it in their E&M coding and stuff like that. In Epic, in a hospital-based system that just has Epic, they already have a built-in module that does that. But like I said previously, we've had to integrate many different EMRs to get there. So the only central way for us to do it currently is through Arcadia.
Awesome. We have another really great question. So who paid the EMR vendor cost of connecting the independent practitioner to your master system? Is that on the doctor or WakeMed?
Okay. So the initial connectors were funded through the ACO. Some EMR companies charge an ongoing maintenance fee for that connector, and the provider is responsible for that, because some don't. Some do, some don't, and stuff. But the initial connections were all done through the ACO, paid for those connections as an inducement to get all practices signed up and on board, and so we could integrate their data.
Okay, great. Let's shift gears and let's kind of talk about, how do you drive technology adoption? How have you been successful?
Yeah, and that's a big thing, because technology is not forefront in a provider's mind, okay? Forefront in a provider mind is diagnosis and treatment. It's not technology. So in order to get practices and providers to buy in, it's really about getting champions within an individual practice who sees the benefit of what the data can do for them. So we usually will within each practice, we usually will try to find a champion. Now, if it's a small 1 or 2 member practice versus a larger 30 or 40 member practice, it makes a difference. But usually we try to find someone who's somewhat tech savvy, certainly interested in tech, and understands the value of some of the predictive analytics that our technology can show. The other thing we do is we have a quarterly newsletter with our providers, and we always have a section where we highlight how the technology has helped with a patient. So bringing it not just on the high level, oh, we got technology, but what has it actually done for a patient? How has the predictive analytics gotten the patient involved in care management? How our care managers were able to solve some problems for a particular patient, avoided an admission or an ER visit, or helped them to get their medications funded, or we have a rideshare program and a meals program. you know, what can we use this technology for to actually impact a patient, not just say, oh, we've done all this great stuff integrating all these EMRs.
That's great. I mean, it's great to hear the success. On the flip side, what do you feel are some big barriers when it comes to bringing in a new technology?
Sure. I can say without a doubt, there is no off-the-shelf piece of technology that works the first time around. They may, you know, vendors will come in and they'll show their products, and the products are great and they do a lot of things. But when you get into the real world and you actually have to deal with all the million variables it takes to get data integrated and get data sorted and processed, it is a very long haul. So anyone who's interested in getting technology into their ACOs and stuff like that, you're going to have bumps in the road. You need to have really good people on the front end to help you. And then you got to be willing to consistently go after what it takes to get it truly integrated. Like I said, it took us a year to get all our practices integrated into Arcadia. We recently went through a transition on our referral management process with Proficient Health, which went a lot smoother because we had learned a lot of good, valuable lessons from Arcadia transition. So we got that up running in a little less than 6 months and stuff. But even still, there are little bugs. There's little pieces of data that doesn't talk. There's little ways that it interprets something. There's always little pieces of things that need to be tweaked and worked on as time goes on. And then invariably, the more you use the system, the more you can actually see some of the flaws in the system and how it could work even better by doing X, Y, or Z addition to it. And we've been working a lot with Proficient Health, for example, to improve the product so it does a better job of fulfilling our needs and make it work, you know, more for what we needed to do. And that's, you're always going to find that because, like I said, when any of these products are created, they're created by, you know, very tech-savvy people, but they're not necessarily the end users. And the end users need an experience that is relatively simple, relatively efficient, and definitely helpful, and not a hindrance to their lives, because there's enough hindrances to the world of practicing medicine nowadays.
Definitely. I'd love to kind of talk a little bit more, and we could probably have a whole hour-long discussion on implementations, good and bad horror stories, all of the like. But after kind of that initial adoption, who manages that vendor relationship and like continued training?
Yeah. So for us, we have a population health manager and her team, and they have constant contact with our practices. So they have an ongoing rotation of contacting the practice managers and getting a sense for how things are going. Are they having problems? What are the problems? How can we fix it? And then they also keep it together on a SharePoint drive so that if there are commonalities between practices of what they're experiencing, we can elevate that to the particular vendor and say, okay, we're finding that these types of referrals are not going through like we thought they were going through. Where's the problem? Where's the technological problem with what's going on? And then the vendor will usually say, you know, we need to change or modify or do whatever it takes to make things happen, because, you know, it's a collaborative process. Okay, they don't know what isn't working until we tell them what isn't working, and we don't know what isn't working until we hear from our providers what isn't working. So we just have to keep rolling it together up the line. We also have a online problem, or basically a SPICE ticket works system, where providers and or practice managers, usually it's practice managers, will send an email ticket in for us to know about a problem, and then they're able to evaluate it. So they can do it whenever. So between those one-on-one meetings with all the providers, so that way nothing has to sit for a long period of time. But you have to constantly be re-engaged with all the providers to make sure that they are engaged and they're seeing the benefit of this technology. Because what happens a lot of times is the first thing that there's a glitch, everyone panics and says, well, I'm not going to do this anymore. And you got to get past that. Okay. You have
Yeah.
to stay true to what it is you're trying to accomplish and get through the glitches.
That's great. So what does the process look like when selecting a new technology? What's that vetting process
Yeah.
for you guys?
Yeah. So, so we always do, we have a subcommittee of our board that will go and evaluate what it is we're trying to accomplish, screen for our vendors for who might have a product for which that would be. Our executive director will then engage all those vendors and create essentially a short list of those that seem to be, really able to meet our needs. We would bring them in and interview them, obviously see demos of the product and stuff like that. And those interviews will usually be 2 or 3 to see. And then once we get down to the 1 or 2 that we're interested in, there'll be another probably on-site evaluation of the product in order to decide about going forward. So you definitely want to spend the time and carefully think about what it is this product is going to do for you, and how easy it would be to implement this product. The idea that you're going to magically change everybody's electronic world all at one time is a bit of a fallacy. It's usually too much of a stretch. So doing things a little bit at a time. So we had our informatics integration. Now we've had our referral management integration. We're looking into a risk management integration and maybe for 2022. You just kind of want to do a little bit at a time so people can kind of digest and then move on. If you try to change it all at once, could be helter-skelter.
Exactly. Well, on that topic, do you have any advice or best practices on how to solicit member input when making new decisions on technology?
Yeah, so what we did when we were vetting the Proficient Health product is we actually went out and reached out to several primary care practices and several of the specialty practices and have them form a work group to see these demos and actually have them ask questions of the vendors. So how it worked for them and their particular ways in which they wanted referrals to happen and stuff like that. So there was about 4 or 5 primary care practices, and I think about an equal number of specialty practices that were able to see and review these products. And then we listened to their feedback in terms of what they thought would work. Would a particular product really be a benefit to them? And that helped us in our decision making too. So the more you can get buy-in early in the game, the easier it is to bring this out. And it's a great way to get champions involved too, because if they've seen the product and they're excited by it, you can rely on them to help be champions to bring the product forward, and say, we looked at all these different things. This is the best thing out there now, and so survive the implementation because it's going to be great on the back end.
Exactly. Well, we have a really great audience question here. How do you make it clear what decisions are made at the network level versus the practice level when it comes to adding new technology?
Yeah. So, all organizations are organized a bit differently. Since our organization is an association between a hospital system and a bunch of independent providers, we cannot ignore the independent providers in the decision-making process. So our board is a 16-member board, 14 of which are physicians. So it is a very heavily physician-dominated board that's making these decisions. Certainly when we do these evaluations for different products, it is mostly actually providers that are making these decisions. And we also will have an ongoing discussion with a monthly practice manager meeting to discuss with the practice managers, because we find that the practice managers sometimes have a better feel for technology and its usage than the individual providers do. The providers obviously are more involved in seeing patients, making diagnosis, recommending treatments. and not always as engaged in terms of what technologies are going to be beneficial to their practice going forward. So this is where actually getting a lot of the practice managers involved has really been very helpful. And through these practice manager meetings we have, we're able to present information about different products and stuff to get their feedback on them. So that's how we try to keep the practices involved. But yes, the major decisions are certainly made by the board, which is, like I said, majority physician run.
Great. We have one more question on this topic before we kind of switch gears, but as you reach out directly to independent practices for input, what role, if any, does the IPA play in the ACO?
Yeah, so the IPA, the way it works is that of our 16-member board, 8 representatives are from the IPA and 8 are from the hospital system. So the IPA has their own elections and put the members onto the board, and those members represent their interests in the decision-making processes. Also, we are obviously constantly in communication between both the WakeMed's, their own internal board, and the IPA's internal board to make sure that everyone is in the loop when such decisions are being made, because it affects everybody and everyone's paying for it. So it's not a decision, any of these decisions we take very lightly, because technology costs money. So it's important that everyone gets buy-in on these things. So yes, getting both the hospital system and the Independent Provider Association on board is critical to making sure you have good success going forward. It does no good for an ACO to come in and force a particular technology on a bunch of, especially independent providers, without showing that it is the best answer for a particular problem.
Awesome, great. Now, we kind of touched on this earlier, but I'd love to spend a few minutes and kind of discuss data analytics and how do we leverage that to make decisions. So do you want to kind of talk through maybe some specific examples of how you used data and analytics from your technology to make, you know, big decisions?
Yeah. So we use it in many different ways, actually. So besides the quality measures, and a lot of that is kind of what's called descriptive analytics, where you just say, okay, well, was a care gap closed or not closed, stuff like that, to actually moving it forward into more predictive analytics, where we're actually able to see which patients are particularly high risk of having problems like ER visits and hospitalizations going forward, and or noticing that there are certain trends where certain providers or practices are not performing as well on a particular measure. So like I alluded to earlier, we looking through all this data, we were able to find out that a number of the practices had fallen way behind on management of diabetics. So we had a fair number of patients with hemoglobin A1C is greater than 8. And this caught our attention because we didn't really realize that. We thought, oh yeah, everyone's getting treated, and in fact, they were not getting treated. And so we did a lot of investigating to figure out what the answer was. And there was a number of things. It wasn't just one thing. Sometimes it was a mismatch on data. So we found out that the ops terms that they were using were not necessarily being captured correctly by the system. We also found out that a number of patients, especially during the pandemic, were not seen. So unless they're seen and have an A1C drawn and recorded, they're considered uncontrolled. Whether they are or they aren't, they're considered uncontrolled. So we were able to help the practices identify those patients in their panels that hadn't been seen in over a year, obviously because of the pandemic and stuff like that, so they could get them in and actually get an A1C, and that helped to close a lot of the care gaps. So then we were eventually able to get down to who were the true patients that were truly uncontrolled despite whatever medical treatments that they were on. So once we got down to that population, we actually put together a diabetes task force of several of the practices in town to kind of work with an endocrinologist in our system to develop a mechanism for how to deal with these patients. And what we came up with was a pilot program using continuous glucose monitors, so CGMs. So what we did is we went to Abbott, which is the manufacturer of the Libre system, and went into a collaborative program with them where they were going to provide CGMs for us, and we were going to use them in patients that didn't necessarily meet the standard criteria. Standard criteria is you had to be on 4 shots of insulin and stuff like that, but we wanted to expand it to use in any diabetic who was uncontrolled. So those that were just on oral agents or maybe just once a day insulin or something like that, to see what the improvements would be. So we got about 130 patients, I believe, enrolled in that. And the last time I looked at the analytics last month, we've gotten 30% of them under control just using CGMs. So that has been very good. As a matter of fact, we presented this information to Blue Cross Blue Shield, and they are in the process of working. They use Dexcom instead of Libre, but they're working with Dexcom now to work on a pilot with us to do a waiver on Dexcom and allowing us to offer this service to even more patients. Now, of course, not every patient will accept it, but we're finding that it's actually fairly well accepted and is becoming much more universal as a lot of TV ads and stuff like that. So the idea of just being able to read your sugar numbers and I can just download them off the cloud and see what a patient's sugar control is just totally awesome type thing. So this is how we've been able to use technology to look at descriptive stuff like how were we doing, figure out where we weren't doing, and then use it to figure out a mechanism for taking care of the problem. And that's the little kinds of insights you can get by having these huge data warehouses and looking at what's really going on, because what you think's going on may not be what's really going on, and what you didn't think was going on probably is going on, and you need to pay attention to it.
That's super interesting. I'm really curious about how do you share this data with your teams? What kind of data do you provide to your members versus what is kept kind of like on the network level?
Yeah. So what we do is we have a quarterly pod meeting. They're called pod meetings, but they're basically group meetings with all of our providers. We have 2 for our adult practices and 2 for our pediatric practices every quarter. And at that meeting, we always present where are our quality measures. So we always present the chart of exactly where where the ACO stands on its quality measures. And then we also talk about what are the initiatives that we're working on. So all this information about the diabetic initiative and stuff like that, we've presented that to all the practices to show how it's working. We also like I said, implemented a rideshare program for patients this year, and we presented that information. We're starting a meals program that will probably start in January. That information has been presented to the practices. So you want to make sure the practices understand and aware of what the ACO is doing to help them and provide services for them so they can better manage their patients.
That's great. We have a couple audience questions here. So this is a great question. With multiple systems integrated, many with the same patients, how do you determine the source of truth when data conflicts?
Yeah. So in general, all patients have a single PCP identified. So the only issue comes in if a patient leaves a particular practice and goes to a different practice, then there's a time lag for the claims data to reassign that patient to a different provider. Luckily, that's a relatively small number, 1% more or less. It's a small number. So all patients are associated with a given PCP. So it's pretty easy to line those 2 things up fairly well. What we do find is, and this is the hard part of, and one reason why we moved to a new referral platform, is that we were seeing a fair number of patients going to other specialists outside of our high value specialists. We're in an area that's got a lot of big medical centers. We got Duke, we got UNC. So we have a fair number of patients that have gone to other health systems for for care, and we don't necessarily get their data until it's claims data. So one of the things about creating this new Proficient Health platform was to get these outside entities integrated into that referral management system, so that way we would know who was going to an outside entity, and to ensure that they were getting the data back to the PCP, and that the ACO could track that utilization over time, so we understand where patients are going and why, and making sure that everything's coordinated appropriately. So yeah, so data gives you insight, but then you got to take the insight and act on it, and it's always tricky.
Tell me a little bit more about how do you empower that action? So you have the data. What are some kind of key steps to make that data happen?
Yeah. Well, most of these platforms and stuff, they'll have built-in reporting systems. So they will give you reports on, time to completion of a referral, or when it's picked up by a specialist and stuff like that. So a lot of stuff are kind of pre-made or canned reports. Even in our Arcadia system, there's a lot of canned reports. But what we actually like to do is to work with the vendors to create specialized reports that are individualized to the needs of particular people. So the team here at WKZC has very defined goals of what they're working on and the kind of reports they need to achieve those goals. But we also empower the individual practices to be able to look at their own data and figure out where they stand on all these reports. So for all these informatics platforms, every practice can go in and look at their own practices, quality measures, referral patterns, and risk scoring and care management. So all these things that we look at the big level, each individual practice has access to data for themselves to understand how they're functioning and where they have care gaps and risk scoring opportunities that they can also take advantage of. So the idea is you don't want to hold the data up here and say no one else gets to see it. We want to make sure the data is available to everyone so they can get the best use out of that data themselves. And so I didn't mention this, but one of the things that's a requirement of an ACO is that all practices have to do 2 PDSAs, Plan, Do, Study, Acts, projects during the year. These are quality improvement projects. And a lot of these practices use these kind of data to figure out where they want to do their quality improvement work, because there's just tons of great data. So if they notice that they're having troubles getting enough breast cancer screening in, I know several practices that have made that their PDSA for the year, and they figured out better ways of capturing mammograms reports and getting them integrated, or colorectal screening, or cervical screening, or immunizations, or any of these other measures that are out there. They use that data to form their own PDSA so they can meet the requirements of being in our ACO. So it's good for them individually, and it's obviously good for us at the ACO level.
Awesome. It looks like we have one more follow-up question here, looking for some maybe specifics on this topic. So to what extent does your system proactively assist independent docs to manage their patients? You indicated that you provide a list of patients with gaps. Does your system integrate gaps into the EMR to provide that type of data for every patient at the point of service?
Yes. So there's a section of Arcadia called Desktop. And Desktop is a pop-up that occurs in the EMR that will give a list of all the care gaps at the point of service, all the risk scoring opportunities at the point of service, and all the care management activities that have taken place and or allow you to refer to care management if you are concerned. And it also gives the impact score, which is Arcadia's measure of how risk a patient is at. So the impact score is a combination of chronic diseases, hospitalizations, medications, socially determined health information, etc., to develop, who is a high impact patient, and then that information is relayed to the providers. But it is done through a point of service plugin to the EMRs, and to be perfectly honest, that's been our big challenge this year. So our big challenge last year was getting all the practices integrated into the Arcadia platform. Our big challenge this year has been trying to get that desktop module integrated into everyone's EMRs. Some have been more successful than others, I would, unfortunately, but we're still working with that. There's supposed to be a big update to the Arcadia platform early next year that should, knock on wood, allow that to happen a lot smoother. But that is the eventual goal, because the last thing we want providers to do is have to be in and out of 3 or 4 different program systems and try to figure out what's what and whatever. It's good to have a integrated, seamless interface for the provider, so then when they're in the room seeing the patient, they know what care gaps need to be filled, what are the risk coding opportunities and stuff like that, so they can manage the patient at the time they're seeing them and not having to do a ton of back work later on because opportunities were missed.
Awesome. All right. Well, this is the last time I'm going to switch up the topic on you, but it's a good one. So, what trends do you think will be most prevalent in 2022?
Yeah. So, and we're already looking at, where do we go from here? That's always a big question. Never sit on your laurels. So there are several things going forward that we've been looking at, especially in the realm of wearable devices. We had a lot of success with the CGM program. So we're actually looking a lot into what can we get out of wearable devices and how to integrate that data into our system to develop even better predictive analytics. So weight scales for like heart failure patients, blood pressure monitors for hypertensive patients, various, and when people got Apple Watches, okay,
yeah,
that can do an EKG and a pulse ox and all this other great information on patients, and figure out ways of integrating that data in to better understand what's going on with the patient. One of the problems we have as practitioners is we see patients for 15, 30 minutes, once or twice a year, and sure, we can collect data, but are we really getting a full picture of what's going on in that patient's life? The answer is probably not. And using wearables as a way, especially in high-risk patients, to get a better insight into how they're doing, get some early information about if they're not doing well so we can act on it and avoid an ER visit or a hospitalization would be awesome. So we're really looking more into that issue of where can we use wearables and remote patient monitoring type systems to kind of help us get a head start on our predictive analytics with these people.
You love to hear it. Well, thank you so much for joining us. We're going to wrap up our session today, trying to keep this under an hour. I know that everyone's schedules are just probably absolutely slammed this time of year. So I'm going to go ahead and pass it back over to Garrett, who's going to have some closing remarks for us.
Great. Well, thank you, both of you. This was a really, I thought, practical and good session where we talked about some real best practices. So I hope everybody really got a lot out of this. I know I did, and wanted to make a note here. A couple last minute things. I'm going to again send everyone who registered out a link to the recording after the fact. We didn't have any slides, as you can see, for today's presentation. We had a couple, like an intro and an outro, but we didn't have a lot of slides. So, but the recording, I'll definitely send that out. If you have any questions, if you would like to reach out to the Proficient team, you can see on your screen here now, Hope is their rep that will be fielding your questions. So feel free to reach out to her, and her email is there on the screen there, and or you can reach out to me, and I'm happy to put you in touch with them. So once again, I want to thank both Dr. Israel and Ms. Grau for your time today. I thought this was great, and I really appreciate everybody taking the time to join us today. I know there's a lot on your plate. So hope you have a happy holidays and stay safe. Thank you.
All right. Goodbye, everyone.
Bye, guys.